Hello and welcome to a new session of Majlis podcast by Emirates Hospital Group. My name is 𝗚𝗷𝗶𝘀𝗀 and I'm a family medicine consultant. Today is another pleasure of meeting Dr. Nathalie and having her with us today to talk about arthritis and in particular rheumatoid arthritis. Hello, Dr. Nathalie.
Hello, Dr. Wael, and thank you for hosting me today. I'm Dr. Nathalie Chalhoub. I'm a consultant rheumatologist at Emirates Hospital Jumeirah.
Very welcome. And today is a very exciting topic and very important. And I'll go straight into the topic. What is rheumatoid arthritis?
So we hear a lot of people saying, I have rheumatoid arthritis or I have rheumatism. So rheumatoid arthritis in particular is a chronic form of autoimmune inflammatory arthritis. And when we say autoimmune, because a lot of people talking about autoimmune diseases, autoimmunity, these are diseases where the immune system, which is supposed to defend the body against foreign antigen, foreign substances like bacteria, viruses, starts working in a little bit of a bizarre way, we say, and starts attacking the tissues and the organs of the body itself, hence the name autoimmune. So it's immunity against self. So rheumatoid arthritis is a chronic disease. It's an autoimmune disease that causes inflammation in the joints. Hence, it's a chronic autoimmune inflammatory form of arthritis. And it usually affects the small joints, so it can affect the hands, the feet, and it tends to happen in a symmetrical way. So that's very characteristic and nice of rheumatoid, not nice, I would say, but characteristic of rheumatoid arthritis, that it can affect the small joints, let's say, of the right hand and the left hand, the joints of the right foot and the left foot. Still, at the early stages of the disease, it can start on one side and then, affect the other side. But a symmetrical pattern is kind of like a feature of rheumatoid arthritis. And it tends to happen in the small joints, but it can also affect larger joints. So even though it can affect like the knuckles of the hands and the wrist, but we can also see it in the knees and the shoulders and the hips, so in larger joints. One more thing I want to mention about rheumatoid arthritis is that it's a systemic disease. And by systemic meaning it affects not only the joints, it can actually affect other parts of the body. So it can affect the skin, the eyes, the lungs, the heart. So it's a systemic disease, autoimmune disease, and it causes inflammatory forms of arthritis.
Well, it sounds very serious, of course, but I'm sure in the safe hands and under the right hands, the treatment is there. But before we go actually and ask you more about the treatment, you mentioned that it can affect the small joints mostly, but also the large joints. So let's say, for example, like I played football yesterday and my feet, and they do hurt actually today, my knees. Could it be arthritis? I mean, how is the diagnosis made? What should I do if I have pain in my right knee? So when should I go see the doctor, and how is the diagnosis going to happen?
So we're going back to the general term of arthritis. When we think of arthritis in general, let's put it into two broad categories. We have mechanical problems. So let's say you said you played football yesterday and then you developed some pain. So that's a mechanical thing that happened while you playing or doing exercise. And then we have the inflammatory forms of arthritis, and this is where rheumatoid arthritis actually falls. So mechanical problems, for example, after injuries, traumas, sprains of, let's say, an ankle or injury to the knee, or even like wear and tear arthritis that happens with age that we call osteoarthritis, versus the inflammatory forms of arthritis that would fall under what I just talked about, the autoimmune diseases, and that cause inflammatory forms of arthritis that can happen at any age, such as rheumatoid arthritis. And then to diagnose, definitely the history is very important, You're telling me you played sports yesterday, I would be thinking more of a mechanical problem versus somebody's telling me my joints just swell up for no reason and I wake up in the morning and I have pain and stiffness after sleeping. So the pattern of disease pain and the pattern of involvement of the joints would be different between the form of arthritis that's related to an injury or a mechanical problem versus arthritis that is related to an inflammatory problem.
Fair enough. So I'm going to skip the part where you call me old and I have wear and tear
that's
arthritis.
Not directed to you.
But on the medical side, and today we go back to it. So what do I expect? Let's say I'm coming to see you because then I'm worried about rheumatoid arthritis. So what do I expect at the consultation? I mean, you said the history is very important. So am I going to get a scan? Am I going to get blood tests? And how do we proceed normally?
So the history is key. Actually, our diagnosis is highly dependent on the clinical history because the pattern of joint pain, which joints are involved, how it progressed, all that is important to know. If other organs also are affected, as I said, rheumatoid arthritis is a systemic disease. So the history is key to make the diagnosis, and then we have the physical exam. So when you go to a rheumatologist, all the joints will be examined, the joints of the upper and lower parts of the body, to look for signs of like joint swelling, tenderness in the joints. Patients might be complaining of stiffness. We also look for, other parts of the body. We examine the skin, the heart, the lungs to make sure that we have a complete physical exam. Now, the blood tests are definitely important, and they come in to support our history and physical exam. We check for inflammation markers. Of course, you check them also in your clinic, the ESR and the CRP. These are markers that get elevated when somebody has active inflammation. But we also check some markers of the disease, such as the rheumatoid factor and the anti-CCP antibody. Those are like substances that are produced in the body, and they are directed against our own proteins. As we said, this is an autoimmune disease. So those markers, if they are positive, that means the person has or is at a higher risk of developing rheumatoid arthritis. And we also check, of course, routine blood tests, such as the blood counts. We want to check the patient doesn't have anemia that could be related to a chronic disease. We check the kidney, the liver functions, specifically before starting new medications for arthritis. Now, the role of imaging in doing like X-rays of the joints is also very important, sometimes to look for any signs of like a joint space narrowing, deformities or change in the shape of the joints, erosions, some soft tissue swelling around the joints that can be detected on imaging. Nowadays, we also perform ultrasounds of the joints, which are actually very helpful, because even at early stages of the disease, we can detect inflammation in the lining of the joint. We call it synovitis, or if there is like fluid inside the joint. And sometimes even before, the patient has like severe symptoms, those can be detected on ultrasound.
And that's very good to hear, because of course the new technology and the access to actually those kind of modalities. But this is maybe an occasion for me to raise now awareness for our listeners, because don't do the blood test before you see the doctor.
That's very true.
Yeah, because I see some people just going in doing their blood test because someone told them to check the rheumatoid factor. So you just highlighted how important the kind of the history, the physical examination, supported by the bloods later.
Exactly. So the blood tests are just here to support. If somebody has a positive rheumatoid factor without any signs of joint pain or joint stiffness or joint swelling, then what are you going to do with a positive rheumatoid factor? You're not going to treat the number alone. And then some people can have all the symptoms, which are the joint pain, stiffness that can last like for half an hour or even an hour in the morning, affecting small joints, joint effusions, meaning like fluid in the joint, and they can still have a negative rheumatoid factor and a negative anti-CCP. This is what we call seronegative rheumatoid arthritis. The diagnosis can be a little bit trickier in those cases, and definitely it can be hard sometimes to differentiate seronegative rheumatoid arthritis from other forms of arthritis. But then we go back to the same point, the importance of the history, the importance of the physical exam in making the diagnosis.
That's very good. And thank you as well for clarifying that, because medical anxiety is a big problem. And then people start worrying that they have rheumatoid arthritis, and in reality they don't. So thank you. Now, the scary part of the disease, if I may say, it's probably the fact that it's multiple system. You mentioned that it could affect the kidneys and many organs. So it sounds scary, but is it doom and gloom? Is there hope? What are the treatments out there?
So, if we look back like many, many years ago, people with rheumatoid arthritis, they used to be like crippled and disabled. But the good news now is that we have so many treatments and so many effective treatments. So an early diagnosis and starting treatments early are key. And they can actually, control the inflammation and decrease the symptoms of pain and stiffness, but also they help prevent, joint damage, maintain a joint mobility, and even involvement of other organs can also be minimized. So we have a lot of treatments.
It's good to hear. But there's always a fear and again, forgive me from my basic knowledge of it, because I hear it from my patients when they come at the level of family medicine. They're afraid of the biologics. They're always kind of this bad, I won't say media, but bad kind of information or misinformation out there. And people are reluctant to say, no, I don't want to take any treatment because it will cause me problems. So what do you say to our audience who are afraid of these treatment or new modalities out there?
So first of all, we don't jump right away into giving biologic therapy. So a lot of patients, when they come to clinic, because they're in pain, they're already taking some form of non-steroidal anti-inflammatory drugs, such as ibuprofen, naproxen, and those can minimize, some of the pain, but they will not prevent the long-term damage on the joints. And as you know, they are associated with some side effects if they are taken for prolonged periods of time. Stomach pain, heart, cardiovascular side effects, etc. So a lot of patients would come and they've already been prescribed steroids, by some other doctors, because steroids, since their introduction, in the 1940s. I believe they were introduced, they have literally changed, the course of patients with rheumatoid arthritis. They are strong anti-inflammatories and they are immune suppressants. So regaining joint mobility, decreasing stiffness can be kind of pretty fast when somebody starts, prednisone or another steroid, but also all the side effects that are associated with it. So we do prescribe it sometimes, but we prescribe it as a bridge until other treatments kick in and start, having a better effect, because some of the medications take a longer time to act. But still, we say the lowest dose for the shortest period of time when we talk about steroids. And then comes what we call the DMARDs, the disease-modifying anti-rheumatic drugs. And I believe that every patient with rheumatoid arthritis should be on a DMARD. You're not going to keep them forever on a non-steroidal or on steroids, so they should be started on a DMARD. And under DMARDs, we have a wide spectrum of medications. We have what we call the conventional DMARDs, so conventional synthetic DMARDs, CS DMARDs, such as methotrexate, sulfasalazine, leflunomide, hydroxychloroquine, and those come in pill forms. Some come, like methotrexate, could be an injectable sometime. And then we have what we call the biologic DMARDs. And people can be scared of either this or that. Some people are scared of methotrexate when they come and they read about the medication and they're scared about it.
Correct.
But actually, this medication has made wonders in the treatment of rheumatoid arthritis. Since it was introduced, and that was not a very long time ago, in the 80s, in 1980s, methotrexate was introduced as a treatment for rheumatoid arthritis. The response to the treatment has been tremendous in terms of, decreasing stiffness, improving joint mobility, decreasing damage in the joints over time, and still a lot of people would do very well on methotrexate alone. So it is the mainstay of treatment for anyone who comes with a first-time diagnosis of rheumatoid arthritis. If it's good enough, then they might do just well enough with one medication. And if not, then we have either to switch to another conventional DMARD, or we go to a biologic treatment, which would be, in most cases, an add-on to methotrexate. And under biologics, every year we have something new, coming up. So the first medications that were used are the TNF inhibitors. So first, biologic, meaning these are substances or drugs that were manufactured from living cells. That's why we call them biologics. And then there are different classes of biologics. The TNF inhibitors that are actually targeting a certain molecule, which is called tumor necrosis factor alpha, which is like an inflammatory cytokine in the body that gets produced in cases of acute inflammation. So those are medications that are inhibiting it to decrease inflammation and hence decrease the swelling, the pain, the joint damage. A lot of people would be scared from those medications, as you mentioned, because if you read the pamphlet, you will read a lot of side effects. And I cannot deny there are definitely side effects. That doesn't mean that every person who takes the medication will develop them, but they have to be aware that our medications, or the medications for rheumatoid arthritis, we call them immune modulators, or some of them are immune suppressants, because it's an autoimmune disease and the immune system is working a little bit in a funny way, attacking its own parts, So we are giving medications to prevent or to minimize the effect of the immune system attacking the body. So some of those medications are immune suppressants, which in some cases can be associated with a little bit of a high risk, let's say, of infections. So this is the main warning we tell patients. And then you might, in your clinic, you vaccinate your patients for routine vaccines. So, of course, patients who are on immune suppressants and at a little bit of a high risk of infections, we recommend that they get vaccinated on time, get their flu shots, their pneumonia vaccine, their vaccine for herpes zoster. So the routine, care that we usually recommend to the general population, we highlight it even more for patients with rheumatoid arthritis.
Thank you very much. My God, I feel like I'm a medical student today, and I might ask you to sign off my logbook at the end because I've attended the session. So thank you. That's very informative. And maybe what I could add about the treatment, and maybe that's an important thing, that yes, the medications might have the side effects, but you're aware of it as a doctor, of course, that you will educate the patients about the side effects. But we have to keep in mind that if we don't treat the disease has bigger side effects. And that's where the balance is, that really the medications, though with the side effects, that they're going to outweigh the risk of the disease.
And that's a general rule in medicine.
Yeah, absolutely.
The benefits should outweigh the risks.
100%.
So there is no reason for somebody to be crippled of rheumatoid arthritis nowadays. I mean, we have all the list of conventional DMARDs. We have so many biologic DMARDs. I mean, we talked about TNF inhibitors. We have even more. We have like the interleukin inhibitors, for example, IL-6 inhibitor, tocilizumab. We have medications that are now even like newer medications that come in pill forms because the previous biologics I talked about, TNF, IL-6 inhibitors, are injections actually. We have now the targeted synthetic DMARDs, which actually target certain pathways called the JAK-STAT pathway, and those come in pill forms such as tofacitinib, upadacitinib, baricitinib. So all of those, we have a long list, and
I'll take your word for it, and that's why
so many are coming up. So many medications. So treating the disease is key, because everyone wants to have a normal life and not feel sick. I mean,
absolutely, and thank you very much for this update. Like I said, I stopped following up the updates, and that's why the rheumatologists are the smart doctors, right? The family medicine, we just now refer to you.
You're also the smart doctor, so you can refer to us, the correct patient.
So you mentioned the impact of certain things that patients should do, maybe in a way. So we talked about treatment, we talked about rheumatoid arthritis, but let's say today I'm your patient and we talked about methotrexate. I'm going to try it. I'm seeing some benefit. What am I supposed to do? What other things? And we mentioned vaccines, and you're absolutely correct that we have to vaccinate and we have to be aware of certain medications could affect our immune system. But what other lifestyle measures I can do on my side to improve my outcome and treatment of rheumatoid arthritis?
So the first thing, that's a very good question, because people always ask, like, what did I do wrong or what should I do? First of all, I'm diverting a little bit from your question. What did I do wrong doesn't exist, because
I understand.
Most people with autoimmune diseases, they have some genetic predisposition, and then there are some environmental factors that come and trigger the disease in one person, not in the other. So prevention in that sense could be a little bit hard, but we can always take the appropriate lifestyle measures as much as we can. And what are those lifestyle measures? In order to, supplement what we are taking from the medication. So we're taking the medications to treat, and then we have also to take our part in having a healthy lifestyle, meaning keeping active, exercising. That's number one, because this is a disease that affects the joints, and we don't want the joints to be stiffer, crippled, and not to lose the function. So a lot of people would say, but I'm stiff, I'm in pain, how can I exercise? Of course, it's hard, but even small steps can go a long way, as we say. Exercises that maintain the joints' range of motion. Exercises to maintain endurance, like swimming. We say like aquatherapy or swimming can be very helpful, because we're not putting so much pressure on the joints. It's just working against water resistance, and at the same time you maintain the mobility of the joints. People who can, let's say, walk fast, like fast walking, or even if they can run, then that's even better. Stretching, any kind of exercise would be helpful. What's important is that the person, when they are exercising, to do what they can, not to push to the point of being in pain. We say the body tells you when to stop. If I'm doing something that's hurting, it means I cannot do more today. Maybe tomorrow I'll be feeling better, I can, do a little bit more. And then at the same time, consistency. What I advise patients is that choose an exercise you like to do. If you hate running and then you're running, you're going to do it for a day or two and then stop.
Absolutely.
Right? But do something you enjoy so you can do it every day and be consistent so you can see results. So exercise, I cannot stress enough, because we want to strengthen the muscles and maintain joint mobility. Second thing is diet. And diet, there is no perfect diet, but we say like in our Mediterranean, in the Mediterranean area, we talk about the Mediterranean diet because it has some anti-inflammatory properties, it has been shown. The reason is because it has a little bit of everything. It has fruits, vegetables, grains, a little bit of meat, poultry, fish. So it's the mixture of all these different kinds of food that helps, maintain, let's say, a healthy immune system, and minimize inflammation. We try to avoid greasy food, lots of oils, heavy meals. So maintaining a healthy diet is key for general health and for, minimizing inflammation at the same time. Smoking.
Yeah.
How much should I talk about smoking? Smoking actually has been shown to be a trigger for rheumatoid arthritis. So
for people who are genetically disposed.
So someone who's genetically predisposed. When we say someone who's genetically predisposed and then gets environmental triggers, one of those environmental triggers is smoking. So first of all, people who smoke and are genetically predisposed can develop the disease. People who have already developed the disease and who smoke respond less to treatment. Yeah. So they may not take the same benefits from the medications if they're heavy smokers.
That's interesting. And I'm assuming when you say smoking, so that it's clear for our audience, we're not talking cigarette smoking, we're talking any sort of smoking.
All sorts of smoking.
Shisha and vaping and all of that.
That's true.
And that's very important.
Cutting down on smoking, stopping if they can, would be like a very positive step in the management plan of a patient with rheumatoid arthritis and any inflammatory type of arthritis.
Okay, very good. So in a way, the saying, no pain, no gain doesn't apply for rheumatoid arthritis. So if my body is aching, then I should stop exercising.
If your body is aching, it means something is wrong.
So don't push yourself.
So we have to check, right? I mean, exercise is very important. But if every time I'm exercising, I feel worse pain, it means maybe I'm not, on the right track. I have to go check with the rheumatologist, with my doctor, if I need to make any changes to my medications, if anything has to be adjusted, something has to be added, or if there is another form of arthritis that is happening at the same time. Because people with rheumatoid arthritis may have at the same time other forms of mechanical problems. Like if they are runners, they can sprain their foot, and the ankle pain, for example, could be from a mechanical injury. So, of course, if there is pain, if there is a stiffness, these are the key symptoms of somebody who has inflammation-type arthritis. Pain, symptoms, swelling in the joints, feeling tired, fatigue is a big symptom also. Feeling like exhausted. If somebody has to rest for 3 hours after exercising, that's not normal. I mean, you might feel a little bit sore, rest for half an hour, but if you have to sleep for 3 hours to recover, then something is off,
God, I feel I have more questions myself because I'm learning today a lot about arthritis and the up-to-date. But this has been an excellent discussion today. Anything else or any last message you want to tell our audience today?
I want to tell the audience that, nowadays we have so many different treatments for rheumatoid arthritis and for inflammatory arthritis in general. So don't wait too long to see a doctor if you have any symptoms of pain in your joints, stiffness lasting like half an hour to an hour in the morning. If you are feeling like your joints are moving not in the optimal way, or if you develop any other symptoms like fatigue, if you're having any skin problems, if you're feeling short of breath, so any symptoms that can happen along with the joint pain, go see your doctor. We have so many treatments for rheumatoid arthritis to prevent, long-term joint damage and long-term disability. And it's always early diagnosis is key to maintaining a normal life and to maintaining an active life and not to be sick.
Dr. Nathalie Chalhoub, our rheumatology consultant at Emirates Group, thank you very much for this lovely session. And this brings us to the end of today's podcast. Stay tuned for our future sessions.